Check, check, check. Hello, ladies and gentlemen. Welcome to Cardiology Lectures. I am Dr. Nik Nikam. I'm a cardiologist. I have practiced cardiology at the Texas Medical Center in Houston, Texas for more than 30 years. Today we are going to learn something about the ACCAH non-ST segment elevation acute coronary syndrome guidelines. This was published in 2015 and this is 2017. So let us begin. Acute coronary syndrome constitutes one of the most important topics for an internist and for a cardiologist. More than 95% of the patients we see as cardiologists in our practice is related to coronary artery disease, and most of the chest pains that present to the emergency room become an important aspect of cardiology practice and also internist practice. So if we understand and master the guidelines set by the American College of Cardiology and the American Heart Association about how we manage the patients with acute non-ST segment elevation acute coronary syndrome, then it would cover more than 75% of what we need to understand about dealing with the patients with coronary artery disease. The overview of this presentation would include assessment of likelihood of acute coronary syndrome. We are also going to look at how we assess the risk of a patient having an acute coronary syndrome that is related to coronary artery disease, non-STEMI or STEMI. So we're going to stratify these patients into low, intermediate, and high risk based on their historic points and physical findings. We're going to determine whether this patient can be safely sent home or admitted to the chest pain unit, telemetry unit, or intensive care unit. We are also going to cover the ACCAH guidelines as far as pharmacotherapy is concerned, along with whether these patients need to be stratified into invasive or conservative management. Finally, we're going to talk about in-hospital management, long-term management, and secondary prevention of coronary events. Acute coronary syndrome is one of the most important admissions to a cardiologist or an internist. More than close to 1.6 million people are admitted to the hospital with acute coronary syndrome, and this was in 2007. It may be close to 1.7 or 8 million patients annually admitted with acute coronary syndrome, of which about 500,000 patients are admitted with acute myocardial infarction or STEMI, and approximately 1.2 to 1.5 million patients are admitted to the hospital with unstable angina or NSTEMI as it is called. So that tells you there are 5 admissions with non-ST segment elevation acute coronary syndrome for every patient admitted with acute myocardial infarction. So it becomes exceedingly important for us to understand each and every guideline set by the American College of Cardiology and the American Heart Association so that we precisely know how to treat a patient with acute coronary syndrome, which drug to use, and how much to use and when to use. So let's learn all those things in this presentation. A little bit pathophysiology of acute coronary syndromes. As you can see, here is a depiction of the coronary artery with a plaque buildup. With rupture of the capsule, there is a formation of a thrombus, but there is a large lumen that is widely open, and this can lead to a patient with unstable angina with normal cardiac enzymes, and these patients can be managed medically. With a little more further progression, there is a rupture of the plaque with a large thrombus formed inside the lumen of the coronary artery, which can lead to significant obstruction to the coronary flow, which can result in an NSTEMI presentation with prolonged chest pain of more than 20 minutes duration, along with the elevated cardiac markers. And we'll discuss how we manage these patients. At the other end of the spectrum, we have a large plaque with a ruptured capsule, leading to coronary thrombosis of the entire lumen of the coronary artery, which leads to total occlusion of the coronary artery, leading to STEMI or ST segment elevation myocardial infarction. I have just completed a separate video presentation on STEMI guidelines by the American College of Cardiology and the American Heart Association, and I would strongly recommend you to watch that video in entirety so that you understand how to manage patients with STEMI. In this presentation, we are going to focus on non-ST segment elevation acute coronary syndromes. The treatment of acute coronary syndrome is based on the presentation. If we have a non-ST segment elevation, the risk assessment is done by taking a careful history, performing a prudent physical examination, and combining that with the initial laboratory tests. We come up with a stratification using several different techniques, of which GRACE score is one of them, and TIMI score, and we're going to talk about both of these momentarily. If the risk is low, these patients are treated conservatively by medications and subjected to stress tests to determine if they have any evidence of reversible myocardial ischemia. On the other hand, this non-ST segment elevation acute coronary syndrome patients have a high risk of subsequent coronary events. They may undergo invasive procedures with coronary intervention and perhaps coronary artery bypass surgery if it is indicated. So much advance in cardiovascular medicine, with such exceedingly high techniques available for opening up coronary arteries and obstructions, still the basic history and physical examination can give us a lot of information about a patient's clinical condition and also about a patient's prognosis. So let us not forget the chest pain, the type of chest pain, the duration of chest pain, the aggravating factors and the relieving factors, because they can have a significant impact on how we understand the pathophysiology of acute coronary syndrome and also predict prognosis. Again, shortness of breath is a totally different indicator of cardiovascular function, which should not be underestimated. Dizziness and the presence of concomitant medical problems do complicate cardiovascular events during a hospital course, so it is important to understand if these patients have hypertension, do they have a previous history of a coronary artery disease, diabetes mellitus, bleeding disorders, peptic ulcer, diverticulosis, kidney problems, things like that. Does this patient have atrial fibrillation, which can have a direct impact on how we manage our anti-platelet and anticoagulant agents in the presence of a high-risk coronary patient. Similarly, patients who are taking phosphodiesterase, such as sildenafil, may have a profound effect on how we treat these patients if we decide to use nitrates. Physical examination is also very important. It can give us a lot of clues about a patient's overall condition and the acute nature of presenting acute coronary syndrome. Is the patient sweating? Is the patient confused? Dyspneic, pulse rate, rhythm, and volume can tell volumes about the patient's cardiovascular function. Similarly, blood pressure, respirations, RAAS, murmurs, and cold and clammy extremities. All of these things can significantly add to the understanding of a patient with acute coronary syndrome right there in the emergency room or on the floor. Here, now we're going to look at some of the ACC/AHA non-ST segment elevation acute coronary syndrome guidelines to help us understand how we approach these patients with acute coronary syndromes. First, we need to get a 12-lead electrocardiogram within 10 minutes of the patient's arrival in the emergency facility. If the initial electrocardiogram is non-diagnostic, it is reasonable to repeat the electrocardiogram 15 to 30 minutes later and look for any evidence of ischemia. Next, we're going to look at serial troponin I and T levels. The troponin level should be obtained at the time of arrival, and it can be repeated if necessary in 3 to 6 hours to determine if there is a progressive increase in the troponin levels. If the initial troponin level is normal, it should be repeated every 6 hours to see if there is an increase in the level of the troponin. According to the ACC/AHA non-ST segment elevation acute coronary syndrome guidelines, with contemporary troponin assays, creatinine kinase, myocardial enzyme, and myoglobin are not useful in the diagnosis of acute coronary syndromes. It may be useful in patients with STEMI, but for acute coronary syndromes, we just basically need to rely primarily on troponin I or troponin T levels. As I mentioned before, the level of troponin can be useful for short and long-term prognosis. And it is reasonable to measure troponin once on day 3 and 4, which will also give us an extent of the myocardial damage and also help us to understand if there is a progressive decline in the troponin level. However, in the present day, with the coronary interventions, the subsequent troponin levels may not be a true reflection of the extent of the myocardial damage, especially after opening a totally occluded coronary artery. It is reasonable to observe patients with the symptoms consistent with the acute coronary syndrome without any evidence of a myocardial ischemia in a chest pain unit or telemetry, with serial EKGs and cardiac troponin levels measured at 3 to 6 hour intervals. With the advent of chest pain units, now we have an accelerated approach to understanding the nature of the acute coronary syndrome, so these patients can be risk stratified at an early stage to determine whether they are going to be treated medically or whether they are going to undergo an exercise test to look for any evidence of reversible ischemia, and then make decisions as to how we treat these patients. This helps us to manage these patients in an expeditious manner. Even a stress echocardiography before discharge may be advisable in patients with normal initial cardiovascular evaluation. This particular guideline refers to coronary CT angiography. If we are dealing with a patient with normal EKG, questionable symptoms, with minimal risk factors, then it is reasonable to perform coronary CT angiography or a rest myocardial perfusion imaging. As far as CT angiography is concerned, this is a regional preference. Some hospitals are equipped to perform CT angiography 24/7, 365 days, and have an on-call radiologist or a cardiologist to interpret coronary CT angiograms and thus rule out significant coronary artery disease within a few hours after an admission to a chest pain unit or a telemetry unit. However, CT angiography also has limitations because the heart rate becomes a major issue which may take several hours to bring it down. Again, we have to have a technologist and a radiologist available 24/7 to perform the CT angiography and interpret the studies as quickly as possible. It is reasonable to give low-risk patients who are referred to outpatient testing daily aspirin, short-acting nitroglycerin, and other medications if appropriate, along with beta blockers. Whenever we discharge a patient from the emergency room, it is exceedingly important to make sure that we are not missing an acute coronary syndrome with a high risk of subsequent cardiac events. So this can only be accomplished by risk stratifying these patients. This brings us to the topic of risk stratification. Patients with suspected acute coronary syndrome and high risk features such as ongoing chest pain, severe dyspnea, syncope, or palpitations should be referred to the emergency department and transported by an emergency medical service to the nearest hospital. How do we assess coronary risk? The TIMI score is one of the most frequently used modalities for assessing the risk of subsequent coronary events. The TIMI risk score uses 7 variables. Each one of them get 1 point. If the patient is more than 65 years, 1 point. More than 3 risk factors such as hypertension, diabetes, hyperlipidemia, smoking, they get 1 point. Prior history of a coronary artery disease, 1 point. ST deviation, ST depression, downsloping ST segment, 1 point. More than 2 anginal episodes during a day, 1 point. Aspirin use in the past 7 days, 1 point. I don't know about aspirin. Everybody takes aspirin or some other type of aspirin derivative. Anyway, elevated cardiac enzymes, 1 point. So based on these risk variables, we add up these points. If the TIMI score is 0 to 1, the risk of all-cause mortality is 4.7%. Whereas if the patient has a TIMI risk score of 3, it jumps up by 3-fold. Whereas if the person has 6 to 7 risk factors, that is a patient who is 70 years old with hypertension, diabetes, hyperlipidemia, smoking, who already has coronary artery disease, with ST depression and multiple episodes of angina, who is already on aspirin with mildly elevated troponin, this patient's risk almost is 10 times compared to a patient with 0 to 1 TIMI score. So this immediately tells us to which category our patient belongs, and it helps us to manage these patients based on their all-cause mortality or MACE events through 14 days after randomization. Here, Gray's risk model is another one that is used, which also looks at CLIPS classification of symptoms. It looks at the systolic blood pressure, heart rate, age, and creatinine levels. So based on that, you can look at here, the risk goes from probability of a hospital death goes from 0.2 all the way up to 44. So this is another way to look at. Most people use TIMI score, and a combination of these two might give us a much better understanding as how we deal with them. Once we have assessed the risk, then we are going to stratify these patients into early invasive strategy or conservative strategy. If the TIMI score is less than 3, especially if it's a female patient with no ST segment deviation, negative biomarkers, they remain stable with no recurrent chest pain, they can be assessed with the stress testing, and if they have an ejection fraction of less than 40 or positive stress test, they go for angiography. On the other hand, if they are having recurrent symptoms, evidence of heart failure or arrhythmias, they go for coronary angiography in the immediate hospital phase. On the other hand, if the patient is a high-risk patient who has a TIMI risk score of greater than 3, who also has hemodynamic instability, electrical instability, refractory angina or PCI in the past 6 months, CABG or low ejection fraction, they go for urgent coronary angiography. What I mean by urgent is within 24 to 48 hours, and undergo coronary intervention if that is most appropriate under the circumstances. While we are doing risk stratification, it is reasonable to obtain supplemental electrocardiographic leads V7 to V9 in patients whose initial electrocardiograph may be non-diagnostic or who have an intermediate to high risk of acute coronary events. These patients should be continuously monitored, and it is reasonable to obtain BNP in patients who are especially having dyspnea with exertion or dyspnea at rest. Now let's look at standard medical therapies, ACC, AHA, non-ST segment elevation guidelines. All of patients should receive oxygen if their oxygen saturation level is less than 90%, or if they are in respiratory distress, or they have high risk features of hypoxemia. This could be a tricky question. They may present you with a young lady with non-specific chest pain and an oxygen saturation of 96%, whether you would use oxygen or not. Next, we're going to move on to anti-ischemic and analgesic medications. All patients with non-ST segment elevation acute coronary syndrome can be treated with nitroglycerin 0.4 milligrams every 5 minutes up to 3 doses, as long as there is no contraindication for use of nitroglycerin. Intravenous nitroglycerin infusion can be used in patients with ongoing ischemia, heart failure, or hypertension. We should be cautious while using nitroglycerin in patients who have received a phosphodiesterase inhibitor such as sildenafil within 24 hours or tadalafil in 48 hours. So that's why taking history is exceedingly important. You have to make sure these patients are not taking phosphodiesterase inhibitors. If they are, then we should be very cautious about using nitroglycerin in these patients. Next, we're going to move on to morphine can be given for control of pain in patients who are not controlled by nitroglycerin and other anti-ischemic medications. Non-steroidal anti-inflammatory drugs, with the exception of aspirin, should be avoided in patients with acute coronary syndrome because non-steroidal anti-inflammatory agents increase the major adverse cardiovascular events. Beta-adrenergic blockers. Oral beta blockers can be initiated within the first 24 hours in patients who do not have the following. We have a long list of contraindications: signs of heart failure, low cardiac output or cardiogenic shock, heart blocks greater than second degree or prolonged PR interval, or if the patient has active asthma or reactive airway. The drugs of choice for treatment of patients with acute coronary syndrome include metoprolol, succinate, which is a long-acting sustained release metoprolol, or carvedilol or bisoprolol. Patients who are documented to have contraindications for beta blockers in the first 24 hours should be re-evaluated to determine subsequent eligibility, because beta blockers do play an important role in managing patients with acute coronary syndrome, both in NSTEMI and also in STEMI situations. One of the contraindications, which we already talked about, is administration of intravenous beta blockers can be potentially harmful in patients who have risk factors for shock. So check the blood pressure before you administer intravenous beta blocker. In patients whom beta blockers are contraindicated, a long-acting calcium channel blocker along with nitrates may be used, especially if the patient has evidence of coronary artery spasm. However, intermediate release nifedipine should not be administered to patients with non-ST segment elevation acute coronary syndrome in the absence of beta blockers. I would say totally avoid using nifedipine in patients with acute coronary syndrome and also in patients with STEMI. Period. Now let's talk about cholesterol. High-intensity statin therapy should be initiated in all patients with acute coronary syndrome, those who have no contraindications for its use. It's reasonable to obtain a lipid profile before we administer the statins, but we don't have to wait for the results to start the statin therapy. Now let's talk about inhibitors of renin-angiotensin-aldosterone system. Inhibitors of renin-angiotensin-aldosterone system, the ACE inhibitors or ARBs, should be started and continued indefinitely in all patients with left ventricular ejection fractions of less than 40% and in those patients with hypertension, diabetes, or stable chronic kidney disease, unless there are other contraindications. Aldosterone blocking agents are recommended in patients with a creatinine of less than 2.5 in men or less than 2 in women whose potassium levels are less than 5 if they have evidence of left ventricular ejection fraction of less than 40%, or if they have a history of diabetes mellitus or a history of heart failure. Now we're going to talk about anti-platelet, anticoagulant therapy in patients with evidence of acute coronary syndrome, which is cardiac in nature. A crash course on coagulation cascade and anti-platelet agents. This is a coagulation cascade, the center of which is the factor 10A, from which we have a common pathway. The purpose of the coagulation is for factor 10A, which is an active form of a factor 10, is to convert prothrombin into thrombin, which acts on fibrinogen and converts fibrinogen into fibrin, which forms a fibrous mesh, which is cross-linked by factor 13, and in which platelets and red blood cells are trapped to create a platelet plug or a thrombus plug, which blocks a damaged artery. So we have the extrinsic pathway here and we have the intrinsic pathway here. The extrinsic pathway involves a factor 12, 11, 9 and 8 in a sequence, whereas extrinsic pathway just involves factor 7, which is converted into factor 7A, and then this acts on factor 10 and the common pathway continues. Now let's talk about some of the drugs that are acting on the coagulation cascade. Warfarin acts on factor 9, it acts on factor 10, and it also acts on factor 7. Whereas apixaban, then rivaroxaban, and betraxaban, they all act directly on factor 10. The dabigatran acts on thrombin directly. Heparin and low molecular weight heparins act on factor 10. Now let's look at anti-platelet agents. Here we aspirin, which blocks the thromboxane A2 receptors, whereas the clopidogrel, prasugrel, and ticagrelor all block the P2Y12 receptors. Then we have the 2B3A inhibitors such as absaximab, eptifibatide, and tirofiban. They act on glycoprotein 2B3A receptors. All patients with acute coronary syndrome should receive aspirin 162 to 325 milligrams unless there is an absolute contraindication for use of aspirin, and they should be continued indefinitely. If for any reason these patients are not able to take aspirin, they can be started on an anti-platelet agent such as clopidogrel 600 milligrams followed by a maintenance dose, which we'll talk about momentarily. The P2Y2 inhibitors such as clopidogrel, ticagrelor, or prasugrel should be administered for up to 12 months to all patients with acute coronary syndrome who have no contraindications, who are treated with either early invasive or ischemia guided strategy. That means those patients who are treated invasively or those patients who receive stents should be treated with clopidogrel 300 or 600 milligram loading dose and a maintenance dose of 75 milligrams daily, or ticagrelor 180 milligrams loading dose followed by 90 milligrams twice daily. However, the patients who receive ticagrelor should take only 81 milligrams of aspirin because of increased risk of bleeding. If the patients are going for an invasive strategy and they have intermediate to high risk of future cardiovascular events, such as evidenced by elevated troponins or a history of coronary artery disease and stent in the past, should receive glycoprotein 2B3A inhibitors such as eptifibatide or tirofiban. Initial parenteral anticoagulant therapy in patients with definite non-ST segment elevation acute coronary syndrome. Now let's talk about a patient who has been admitted to the hospital with minor changes in the electrocardiogram or a slight elevation in cardiac enzymes. These patients can also receive enoxaparin 1 milligram per kg subcutaneously every 12 hours. The dosage can be adjusted based on the creatinine clearance. If the creatinine clearance is less than 30 ml, the dose should be reduced to 1 milligram per kg once daily. Here it says an initial intravenous loading dose of 30 milligrams should be given. This is the first time I have seen this one. Generally, we start these patients on 1 milligram per kg subcutaneously if they have a normal kidney function. Bivalirudin, which can be given as a 0.1 milligram per kg loading dose followed by 0.25 milligram per kg per hour in patients with acute coronary syndrome who are considered for angiography and or PCI. This is generally used in patients who are going to the cardiac catheterization lab. I have used them mostly in the cardiac catheterization lab during coronary intervention. It is generally not used in an intensive care unit, those who are just being screened for acute coronary syndrome. Similarly, fendaparan 2.5 milligrams daily can be given and continued until the patient undergoes PCI. If the patient who is receiving fendaparan undergoes PCI, they should also receive an anti-2 agent such as unfractionated heparin. Non-ST segment elevation acute coronary syndrome patients should not receive intravenous fibrinolytic therapy. This can be asked as a question for your medicine or cardiology boards. Ischemia guided strategy versus early invasive strategy. An immediate or urgent invasive strategy may be employed in patients who have refractory angina or hemodynamic or electrical instability. An early invasive strategy may also be indicated in patients who have elevated risk for clinical events. We talked about this in the TIMI score. If they have more than 3 TIMI score, then these patients should be considered for early invasive strategy. Similarly, invasive strategy can also be considered within 24 to 48 hours in patients with acute coronary syndrome who are high risk candidates. In an initially stabilized patients, an ischemia guided strategy may be considered for patients with non-ST segment elevation acute coronary syndrome without serious comorbid conditions who have an elevated risk for clinical events. Early invasive strategy, diagnostic angiography with an intent to perform revascularization is not recommended in patients with extensive comorbidities such as hepatic, renal, or pulmonary failure, cancer, in whom the risk of revascularization and comorbid conditions are likely to outweigh the benefits of revascularization by coronary intervention. It is also contraindicated in patients with chest pain with low likelihood of acute coronary syndrome who have normal troponin, who have negative troponin levels, and especially in women. Here is a chart which shows the risk stratification based on the number of risk factors. Immediate invasive strategy within the first couple of hours may be indicated in patients with refractory angina, signs of heart failure, hemodynamic instability, recurrent angina, sustained VT or VFib. So these patients should undergo angiography and intervention within the first 2 hours. Ischemia guided strategy can be involved in patients with low risk who have a TIMI score of 0 to 1, low risk in troponin negative female patients, and patients with clinical preference in the absence of high risk features. Early coronary intervention, that is within 24 hours, may be indicated if the GRACE risk score is greater than 140, if there are serial changes in the troponin and EKGs, troponin levels and the electrocardiograms, whereas delayed or invasive within 25 to 72 hours may be considered in patients who have history of diabetes, who have history of renal insufficiency, where the left ventricular ejection fraction is less than 40%, early post-perfusion angina, or a PCI within the previous 6 months, history of prior coronary artery bypass surgery, or a GRACE risk score between 109 and 140 with a TIMI score greater than 2. So this helps you to time your invasive approach based on the severity of the symptoms and clinical findings. Myocardial revascularization, a strategy of multi-vessel PCI in contrast to culprit lesion only. In contrast to culprit lesion only PCI, a strategy of multi-vessel PCI may be reasonable in patients undergoing coronary revascularization as a part of non-ST segment elevation acute coronary syndrome. This is directly in contrast to patients with STEMI who should be undergoing PCI of the culprit vessel only, and subsequently a myocardial perfusion imaging should be performed if necessary to assess the degree of hemodynamic compromise in the coronary arteries other than the culprit coronary lesion. Now we're going to look at anti-platelet anticoagulant therapy. In an acute coronary syndrome patient who is being considered for invasive strategy because of high risk, they can be started with P2Y12 receptor inhibitors. These include clopidogrel 600 milligrams or prasugrel 60 milligrams or ticagrelor 180 milligrams. However, there are certain footnotes for ticagrelor where the aspirin dose should be reduced to 81 milligrams, and prasugrel should not be used in patients with a history of TIA or stroke in the past. High-risk patients who are undergoing PCI should also be treated with glycoprotein 2B3A inhibitors such as absaximab, eptifibatide, or tirofiban. More recently, I think the antithrombin drug such as bivalirudin is routinely used in place of these drugs in the cardiac catheterization units. Anti-platelet anticoagulant therapy. After PCI, it is reasonable to use 81 milligrams of aspirin per day in preference to a higher maintenance dose, as these patients are going to be receiving other antiplatelet agents. The P2Y12 inhibitors should be continued for a minimum of 12 months following a coronary intervention, and they may be continued beyond 12 months. As I already mentioned, prasugrel should not be administered to patients with a prior history of stroke or transient ischemic attack. An anticoagulant should be administered to patients with non-ST segment elevation acute coronary syndrome who are undergoing PCI to reduce the risk of intracoronary or catheter thrombus formation. This can be accomplished by using unfractionated heparin or bivalirudin. Actually, bivalirudin is the preferred drug of choice in patients undergoing coronary interventions. If the patients are already receiving enoxaparin as part of the treatment for acute coronary syndrome, an additional dose of 0.3 milligram per kg IV enoxaparin could be administered at the time of PCI to patients with non-ST segment elevation acute coronary syndrome who have received fewer than 2 therapeutic doses of enoxaparin. Similarly, patients who are started on fendaparonox, if they are going for PCI, an additional 85 units per kg of unfractionated heparin intravenously can be given before PCI because to minimize the risk of catheter thrombosis. Once the patients undergo PCI, the anticoagulants may be reasonably stopped. The usual practice is to continue the bivalirudin for another 1 to 2 hours following PCI to allow time for the antiplatelet agents to take effect, and after that the bivalirudin is discontinued. As I mentioned already, patients who are undergoing PCI, bivalirudin can be used as a monotherapy during the intervention, and these patients can be started on antiplatelet agents immediately following the PCI. Fendaparonox should not be used as a sole anticoagulant to support PCI in patients with acute coronary syndrome due to an increased risk of catheter thrombosis. This is more for cardiology fellows and cardiologists. Now let's talk about the timing of urgent coronary artery bypass surgery in patients with non-ST segment elevation acute coronary syndrome in relation to the use of antiplatelet agents. Patients undergoing coronary artery bypass surgery can continue with their aspirin during and after surgery. However, if the patients are going for elective bypass surgery, clopidogrel ticagrelor should be discontinued for at least 5 days before surgery, and prasugrel should be stopped for 7 days before surgery. However, if these patients are going for urgent coronary artery bypass surgery, clopidogrel and ticagrelor should be discontinued for at least 24 hours to reduce major postoperative bleeding. If patients are referred for coronary artery bypass surgery, short-acting intravenous glycoprotein 2B3A inhibitors such as eftafabatide or tirofiban should be discontinued for at least 2 to 4 hours before surgery, and absaximab should be discontinued for 12 hours before surgery. If patients are referred for urgent coronary artery bypass surgery, it may be reasonable to perform surgery less than 5 days after clopidogrel or ticagrelor has been discontinued, and similarly less than 7 days after prasugrel has been discontinued. Again, we have to weigh the risk versus benefits. Risk stratification before discharge for patients with an ischemic guided strategy for non-ST segment elevation acute coronary syndrome. Non-invasive stress testing is recommended in low and intermediate risk patients who have been symptom-free with low level of activity for a minimum of 12 to 24 hours. Treadmill exercise testing may be useful in patients who have normal electrocardiograms and very low risk of coronary events. Stress testing along with an imaging modality should be used in patients who have abnormal electrocardiograms and who are unable to perform abnormal electrocardiograms and who are undergoing low-level exercise tests. Stress testing with an important imaging modalities such as myocardial perfusion imaging should be used in patients who are able to exercise but have abnormal electrocardiograms and who are undergoing low-level exercise. Pharmacological stress testing may be indicated in patients who have physical limitations which preclude them from performing exercise tests. A non-invasive imaging is recommended to evaluate left ventricular function in patients with definite acute coronary syndrome. This may involve a two-dimensional echocardiogram or a nuclear stress testing. Late hospital care, hospital discharge, and post-hospital discharge care. The medications these patients were receiving during the hospital course should be continued after discharge. Titration of the doses may be required. These patients should also be prescribed sublingual nitroglycerin or nitroglycerin spray and be given verbal and written instructions. All patients discharged from the hospital following an acute coronary syndrome should be informed about the worsening of symptoms and when to report to a physician if their symptoms recur. Before hospital discharge, all these patients should be given culturally sensitive verbal and written instructions about their medications, dosage, frequency, diet, exercise, and when to follow up. For patients who are post-acute coronary syndrome, have initial angina lasting more than 1 minute, a nitroglycerin is recommended. If angina does not subside within 3 to 5 minutes, they should call 911. These patients should also be advised that there are any changes in their symptoms, or if they have noticed new symptoms, they should contact you or report to the emergency room. Patients should also be educated about modifying ongoing cardiovascular risk factors. late hospital and post-hospital oral anti-platelet therapy. Aspirin should be continued indefinitely, and those patients who have undergone PCI or stent placement should be receiving clopidogrel 75 milligrams daily, or ticagrelor 90 milligrams twice daily, or prasugrel 60 milligrams daily. Those patients receiving ticagrelor should reduce their aspirin to 81 milligrams daily. Combined oral anticoagulant therapy and antiplatelet therapy in patients with acute coronary syndrome. It is not uncommon for patients with acute coronary syndrome to be on triple antithrombotic therapy. Think about a scenario where a patient gets a coronary stent who has an underlying heart valve problem for which the patient is already on warfarin, or the patient is on warfarin or antithrombin agents because of atrial fibrillation. Then the duration of a triple antithrombotic therapy with vitamin K antagonists along with aspirin and P2Y12 receptors in patients with acute coronary syndrome should be minimized to the extent possible to limit the risk of bleeding. Sometimes it may be impossible and they may have to be on these drugs long term. When these patients are on triple antithrombotic drugs, we should consider proton pump inhibitors in patients with history of gastrointestinal bleeding to minimize bleeding complications. Even in those patients who do not have history of gastrointestinal bleeding, it is reasonable to use proton pump inhibitors if these patients are receiving triple antithrombotic agents. When these patients are on triple antithrombotic agents, we should use a lower INR ratio of 2.0 to 2.5 to minimize bleeding because of a combination of triple antithrombotic agents. Risk reduction strategies for secondary prevention. Now you have a patient with a documented history of coronary artery disease. We have placed in a stent. This patient has hypertension, diabetes, elevated cholesterol level, smoking. Now our next approach is how do we deal with these patients? All eligible patients with acute coronary syndrome should be referred to a comprehensive cardiovascular rehabilitation program before hospital discharge and during the first outpatient visit. These patients should also receive pneumococcal vaccine. Patients should also be educated about appropriate cholesterol management, blood pressure management, smoking cessation, diabetes control, weight reduction, and physical activities. Patients who have undergone PCI or coronary artery bypass surgery should derive benefits from risk factor modification, receive counseling that revascularization just fixes the mechanical problem, but the patient still needs to focus on a lifetime basis on the ongoing risk factors such as hypertension, diabetes, smoking, weight, diet, exercise, etc. Before hospital discharge, patients' need for treatment of musculoskeletal symptoms must be addressed. Pain treatment should be before consideration of non-steroidal anti-inflammatory agents should begin with pain treatment before consideration of NSAIDs should begin with acetaminophen, non-acetylated salicylates, or small doses of narcotics if these medications are not adequate. It is reasonable to use non-selective, non-steroidal anti-inflammatory drugs such as naproxen if initial therapy with these drugs are inefficient. NSAIDs with increasing degrees of relative cyclooxygenase 2 selectivity may be considered for pain relief only for situations in which intolerable discomfort persists despite attempts at stepped care therapy with acetaminophen, non-acetylated salicylates, tramadol, or small doses of narcotics. Antioxidants and folic acid treatment has not shown to be beneficial in patients with acute coronary syndrome. Hormone therapy and non-steroidal anti-inflammatory agents with high degree of relative cyclooxygenase selectivity should be avoided in patients with acute coronary syndrome. There is no evidence of benefit from hormone therapy in patients with acute coronary syndrome. Plan of care for patients with non-ST segment elevation acute coronary syndrome. Post-hospital system of care designed to prevent hospital readmissions should be used to facilitate the transition to effective coordinated outpatient care for all patients with acute coronary syndrome. That is, all patients who are discharged from the hospital should be prudently followed by specialists to make sure that we avoid any repeat hospital admissions. Evidence-based plan of care that promotes medication adherence, timely follow-up, healthcare team, and appropriate dietary and physical activities and compliance with interventions for secondary prevention should be provided to patients with acute coronary syndrome. The patient should also receive instructions on activities, how much weight they can lift, flights of stairs they can climb, about their household activities, and when they can resume driving, when they can return to work, and about sexual activities. Annual influenza vaccination is also recommended for patients with acute coronary syndrome just before discharge or during the follow-up. Now we're going to look at some special patient groups. Older patients. Older patients, just by the nature of their age and comorbid conditions, are usually high-risk candidates, and they should be considered for early invasive strategy. Pharmacotherapy must be very carefully evaluated in elderly patients who are on multiple drugs, who also have comorbid conditions which can increase their sensitivity to certain drugs. Management decisions regarding older patients with acute coronary syndrome should be patient-centered, considering the patient's preference, goals, comorbid conditions, age, functional status, and life expectancy. If we are considering coronary intervention, bivalirudin should be a preferred drug compared to glycoprotein 2B3A inhibitors. It is reasonable to choose cabbage over PCI in older patients who have multi-vessel disease with a syntax score of greater than 22, or who have left main or heart failure and cardiogenic shock. Patients with history of heart failure and non-ST segment elevation acute coronary syndrome should be treated according to the same risk stratification guidelines and recommendations as for patients with heart failure. Selection of revascularization strategy should be based on the degree, severity, and the extent of a coronary artery disease, associated cardiac lesions, and the extent of left ventricular dysfunction, and a history of prior revascularization procedures. Early revascularization is recommended in patients with a cardiogenic shock due to cardiac pump failure after non-ST segment elevation acute coronary syndrome. Patients with diabetes, medical treatment in acute phase of acute coronary syndrome, and decisions to perform stress testing, angiography, and revascularization should be similar in patients with or without diabetes. However, certain drugs may vary depending upon the presence of diabetes. For example, ACE inhibitors or ARBs should be used in patients with diabetes mellitus. Patients who already had previous coronary artery bypass surgery. Patients with a prior coronary artery bypass surgery and acute coronary syndrome should receive anti-platelet and anticoagulant therapy according to the GDMT and should be strongly considered for early invasive strategy because of their increased risk. Perioperative acute coronary syndrome related to non-cardiac surgery. Patients who develop acute coronary syndrome following non-cardiac surgery should receive GDMT as recommended for patients with the general population, but with the modification imposed by the specific non-cardiac surgical procedure and the severity of acute coronary syndrome. If patients develop acute coronary syndrome following non-cardiac surgery, management should be directed by the underlying cause. It is not uncommon to see patients with EKG changes and even elevated cardiac markers following non-cardiac surgery, and they should be treated appropriately based on the clinical presentation. Patients with chronic kidney disease. Creatinine clearance should be estimated in patients with acute coronary syndrome, and doses of renally cleared medications should be adjusted according to the pharmacokinetic data for those specific medications. Patients undergoing coronary and LV angiography should receive adequate hydration, and we should minimize the amount of contrast used in patients with renal insufficiency. An invasive strategy is reasonable in patients with mild, that is stage 2, or moderate, that is stage 3 chronic kidney disease. Women with acute coronary syndrome should be managed with the same pharmacological therapy as that for men for acute care and for secondary prevention, with attention to weight and renally calculated dose adjustments of anti-platelet and anticoagulant agents to reduce bleeding risk. Women with acute coronary syndrome and high-risk features should undergo early invasive strategy. Women with non-ST segment elevation acute coronary syndrome and low-risk features should not undergo early invasive treatment because of lack of benefit and possibility of harm. Patients with anemia, bleeding, and transfusion. All patients with acute coronary syndrome should be evaluated for the risk of bleeding. Anticoagulant and antiplatelet therapy should be weight-based where appropriate and should be adjusted when necessary based on kidney function and risk of bleeding. A strategy of routine blood transfusion in hemodynamically stable patients with acute coronary syndrome and hemoglobin levels greater than 8 is not recommended. A word about cocaine and methamphetamine users. We should be cautious about using beta blockers in these patients with acute coronary syndrome with a recent history of cocaine or methamphetamine use who demonstrate signs of acute intoxication due to risk of potentiating coronary spasm. As you know, cocaine and methamphetamines cause coronary spasm, and beta blockers may make the coronary spasm worse and hence make their cardiac symptoms worse. Otherwise, they should be treated appropriately with the nitrates, and if they are having tachycardia or hypertension, we should use beta blockers. Prince metal angina. Calcium channel blockers alone or in combination with long-acting nitrates are useful for patients with vasospastic angina. These patients should also be receiving statins and be advised smoking cessation and risk factor modifications. Coronary angiography is recommended in patients with episodic chest pain accompanied by transient ST segment elevation to make sure that we rule out obstructive coronary artery disease. When these patients are undergoing coronary angiography, it is reasonable to perform provocative tests using ergonovin, acetylcholine, or methyl ergonovin to induce coronary spasm. If these patients do show evidence of a coronary spasm, they can be treated with nitrates and calcium channel blockers. Acute coronary syndrome with angiographically normal coronaries. If coronary angiography reveals normal coronary arteries and endothelial dysfunction is suspected, invasive physiological assessment such as coronary flow reserve could be measured in the cardiac catheterization lab during cardiac catheterization. A word about stress cardiomyopathy or Takotsubo syndrome. Takotsubo syndrome should be considered in patients who present with apparent acute coronary syndrome and no evidence of coronary artery disease on angiography. A ventriculography or an echocardiography, echocardiography or a magnetic resonance imaging should be performed to exclude the diagnosis of Takotsubo cardiomyopathy, which showed evidence of distension of the left ventricular apex. Patients should be treated with conventional treatment of heart failure, including diuretics, ACE inhibitors, beta blockers, and aspirin. Anticoagulants may be used in patients who develop left ventricular thrombus. Quality of care and outcomes for acute coronary syndrome. If you are the director of a chest pain program at your institution, it is reasonable to join quality of care outcomes organization where you can share data with other organizations and see how your approach to managing patients with acute coronary syndrome at your institution measures up compared to other institutions. It will be a great place to learn how other institutions are managing similar situations and thus help you to form a better plan in the future to manage these acute coronary patients. So, ladies and gentlemen, this is a long-winded coverage of the acute ACC AHA non-ST segment elevation acute coronary syndrome guidelines 2015. But this is an exceedingly important topic for us to understand fundamentally, because as I said at the beginning, more than 90% of cardiology is based on dealing with patients with the coronary artery disease and its manifestations. And of course, non-ST segment elevation coronary acute syndrome is one of the most important ones when we are seeing these patients in an emergency room or in a hospital situation, and then after that following them on an ongoing basis. Thank you so much for your attention, and please do subscribe to our YouTube channel, and we will see you next time. I am Dr. Nik Nikam, and thank you so much for your time.